This video will review our non-transport documentation. For overview, we'll look at cancels, AMA versus RMAs, assists, standbys, and we'll review our updated list of dispositions. For the cancel disposition, the use is for no patient contact. It means you didn't talk to the patient, you didn't see the patient. Again, no patient contact. A few examples here. You respond to an MVA and you're canceled en route either by the supervisor or law enforcement or dispatch. The supervisor responds to a call with you. They get on scene and determine that it's not needed. You're on a standby for law enforcement while they're clearing the scene and they cancel you for no medical need. These are examples of cancel charts. Again, all of these have no patient contact. Next, let's look at the AMA versus RMA dispositions. They are similar but very different. First, we'll look at AMA. AMA stands for Against Medical Advice. The patient allows you to do an assessment, and with that, there are some requirements. You must have 2 vital sign sets, a blood glucose, 12 and 15 leads, and a 100% completed AMA form within ASO. For the BGL and the 12 and 15 leads, those can be used when applicable. So let's look at the examples to help kind of guide you on this. Let's say you respond to an MVA, either with or without injuries, but you're suggesting the patient be evaluated at the ER for potential fractures, let's say. In that case, maybe a BGL and a 12 and 15 lead aren't really applicable, but maybe it is. Let's say that patient fainted or passed out while driving and that caused them to crash the car versus somebody hit them. So if somebody hit them, probably don't need a glucose and a 12 and 15 lead, but if they were to pass out, then a 12 and 15 lead and a glucose would probably be indicated. Next, hypoglycemia. This is simple, right? Sugar is low, of course you're going to need a glucose. We're either reporting lethargy or some sort of vague symptom, and that's when you should be doing the 12 and 15 lead every time. In general, if you're unsure about whether to obtain a BGL and a 12 and 15 lead, just do them if you're unsure versus to not do them and wish you had done it later. Next, for the refusal of medical assessment, this is when the patient does not allow you to do an assessment. There are still requirements for this. They have to be able to document the patient is ANO times 4 and GCS 15. You can either do that in the vital signs or in the assessment section. It's your choice, or both. Either is fine. They must complete the RMA form, 100% completion within ESO. The patient must be free of complaints and have no obvious medical or traumatic condition that you can observe. The example here is you get an MVA rollover because it was icy, patient's already out of the car, they're like, no, I don't want to be assessed, I'm totally fine. Then you would do an AMA versus an RMA. For the lift assist patient, they're totally refusing assessment. They're like, hey, I'm fine, I just need help up. But again, no complaint, no obvious medical or traumatic condition. For the assist disposition, there are 2 options, assist unit and assist agency. For assist unit, this is primarily used for blood draws and for fire department rehab. Fire department rehab is when there's an incident and you're simply assessing vital signs. There is no medical complaint. For assist agency, this is when you are the second arriving unit. You're assisting another unit with a code or maybe a lift assist on a medical call. Doesn't matter whether it's HGH or another agency such as Lander. You will not document any patient care details, only the patient demographics. For standby, the use is for pre-planned, scheduled events in which EMS coverage is requested. Examples are drag races, football, rodeos, etc. For the transport dispositions, there are only 2 options now. Transport lights and sirens or transport no lights and sirens. For the non-transport dispositions, this is the complete list. Under the line, we have not covered those yet, and we'll do that now. First one, patient treated, transferred care to another EMS professional/unit. This is when you were the first unit on scene and then you transfer patient care to another EMS provider or professional. This is most commonly done with an air ambulance. The next two are patient dead on scene, either resuscitation attempted or no resusc attempted. Self-explanatory. Either you tried to resuscitate or you did not try to resuscitate. We'll finish this video with a couple of notes. So I wanted to just talk about that non-transport patients are the highest risk for you legally, for your license, for any issues that you could arise is when you are on scene and you make patient contact and you make an assessment and you leave them there and don't transport them. That's the highest risk to an EMS personnel. Make sure you document as detailed as possible. These are the charts that are really important for you to take your time and be very detailed in. Next, this video is just a simplified discussion to kind of help orient you to what we're supposed to be doing. There's going to be a lot of questions that these videos cannot answer. So if that happens, if you're uncertain, please reach out to Kevin or myself prior to locking in the charts. This concludes the non-transport documentation video.